Good morning, good afternoon, and good evening from everyone who is joining us from across the globe. My name is Magnus Conte, and I'm the Executive Director for the Community Health Academy. And on behalf of the Academy, I would like to welcome you all today to this webinar, which is focused on the timely topic of compensation and incentivization of community health workers. Before I turn over to our moderator to lead us through today's conversation, I would like to give a brief introduction to the Community Health Academy and the impetus for today's event. The Community Health Academy is an initiative of Last Mile Health, which is reimagining the education of community health workers and health systems leaders for the digital age, equipping over 16,000 community health workers with immersive, interactive, up-to-date training tools deployed over smartphones by 2023. Creating a global classroom to enroll and upskill over 15,000 community health systems leaders by 2021. The Academy's first leadership course, titled Strengthening Community Health Worker Programs to Deliver Primary Health Care, was launched on May 9th this year. The course has now over 11,000 learners enrolled from over 180 countries. This webinar is part of a series intended to supplement the online course learning and provide opportunities for learners and our global community health to interact with each other and to ask questions with community health global experts. It is now my singular honor and privilege to introduce our moderator for this event, Claire Qureshi. Ms. Qureshi is the Senior Advisor for Frontline Delivery for the Community Health Acceleration Partnerships, part of the Office of the WHO Ambassador for Global Strategy, where she focuses on accelerating community health efforts in the US and globally. Previously, Ms. Qureshi served as the Vice President for Frontline Delivery at the Office of the UN Special Envoy for Health, where she co-led community health initiatives designed to support countries in reducing maternal and child mortality and achieving globally agreed health goals. She has a wealth of professional experience spanning global health, finance, economics, and government. We are honored to have Ms. Qureshi as our moderator for today's event. And with that, I will turn over to Ms. Qureshi to kick off the discussions. Thank you.
Thank you. Thank you so much, Magnus. I've had the honor of working closely with many credible leaders from Last Mile Health over the years, including Raj Punjabi, Risha McCormick, Nan Chen, and yourself. And it's really my privilege to be a part of this webinar series. The introduction is far too glowing. I'm really just someone who's feels very privileged to be part of the community health ecosystem. Before we begin, I'd like to take a moment to introduce my esteemed panelists who are much more central to today's discussion than myself. First, it looks like Burnett Pine from the Navajo Nation, who's a CHW supervisor from the Community Outreach and Patient Empowerment Program, may have joined us. I think we need to just point your camera a little bit lower if possible. I know they've had a little trouble getting set up, but thank you so much for joining us, Burnett. Welcome. Next, Catherine London, who is a principal for health law and policy at UMass Medical School and joins us today from Boston. And finally is Shreya Kangovi, who's executive director at the Penn Center for Community Health Workers and is in Philadelphia today. Just a note also, unfortunately, Sarah Seelig, who is an associate physician in the Division of Global Health Equity at the Brigham and Women's Hospital, and who was hoping to join us today, isn't able to participate in the panel, unfortunately. Following these bios, I'd just like to frame the topic a bit and then turn to the panel. As many of you have heard, the US spends more on healthcare per capita than any other nation in the world, approximately $11,000 per person per year as of 2018. Despite this spending, the US has so far failed to achieve health outcomes at the same level as other high-income nations. And the US Centers for Disease Control just recently showed that American life expectancy is continuing its recent annual decline. While US health outcomes are not good, they're also very inequitable. Health outcomes across populations within the US vary dramatically across groups by income, race, and geography. As an example, you can move within 10 blocks in New York or Philly or any other city probably, and you can see dramatic differences in life expectancy. Among certain demographic groups, you really can also see this inequity in vivid contrast. Black women, for example, are 3 to 4 times more likely to die during childbirth than white women in America. Both the failure of high spending to lead to better outcomes and the disparities in health point to the critical role of non-clinical social factors in healthy lives. I believe, as do many on this panel, that the solution to this problem is the development of different kinds of care models. These care models should, 1, bridge the gap between clinical and community settings, and 2, focus on health and wellness, not just on treating disease. Experience in the US and around the world, as everyone on this call knows, has shown that such a care model can and should be built to include community health workers, non-clinical workers who come from the communities of the patients they serve. CHWs are already a part of the American healthcare landscape. In 2005, HRSA estimated that there were around 121,000 CHWs in the US, which is approximately the same ratio as you'd find in Ethiopia, for example. Although this estimate is tremendously uncertain, to say the least. However, while CHWs have long existed in the US, programs have struggled to achieve the combined mission of health impact and financial sustainability. But major changes to the US healthcare system, driven by shifts from fee-for-service to value-based service delivery, provide an important opportunity for renewed efforts to develop large-scale sustainable CHW programs. Indeed, we're seeing some states take leadership roles in this, from Massachusetts, where Catherine is, to New Mexico, to North Carolina, to Pennsylvania and other states, enacting supportive policies around financing and around things like certification. However, major challenges remain with sustainability, and we'll explore those challenges today. So with this pretext, let me now bring in our esteemed panel to give us their insight on community health workers. We'll have about 35 minutes where I'll help moderate, and about 20 minutes at the end for audience Q&A. And please do submit your questions and thoughts on the Tech Change platform. I'll be getting live texts about those and updates to hopefully be able to pepper those into the discussion. I'm hoping our panel can really help us understand the role of CHWs, the challenges to broader scale, and provide recommendations to address these challenges. So Burnett, if you're okay there with the technology, I was hoping we could start with you and give us a 1-minute overview or a few-minute overview of what your day is like as a community health worker supervisor for the Navajo Nation. What do you do? What kind of patients are you seeing? Hi, bring us to the front lines.
All right, thank you again. Hello, everyone. I have a special treat for you guys. I actually have all the supervisors for the Navajo Nation Department of Health here, along with my supervisor, Major Lane Begay, who is actually the head of the department for the Navajo Nation CHR Outreach Program. They can actually share their ideas quickly, letting you know exactly how they actually start off their day for an average CHR going out into the field, getting into the GSA federal unit, transportation, also as well as having a set schedule on how they can actually start off their day doing field visits. Each area is different. There's 8 service units across the Navajo Reservation, which basically at times is related to and actually compared to the state of West Virginia. Within the Navajo Nation as an Indian reservation as the largest land-based federally recognized tribal nation, it actually has a total of, I would say, 110 chapter houses. community health representative. So imagining that and traveling for like maybe hours, two to 3 hours, maybe at the least an hour to visit a critically ill patient, or either that or do a home visit, joint home visit with a public health nurse to provide continuing health education also, as well as other preventive health education in the realm of public health. We're actually an extension of the IHS facility, meaning that we work closely with paraprofessionals, also as well as the physicians, and again, with community members, also as well as the chapter houses that are actually encompassed within the Navajo Nation. They start off, the CHRs on the Eastern Agency side, they basically start off their day by greeting the dawn, asking for a safe day, also as well as providing needed assistance to the chronically ill Native Americans on the Navajo Nation. The chronic illnesses range from obesity, also as well as gestational diabetes. And other things that we actually have encountered is the staggering increase of sexually transmitted disease such as gonorrhea, syphilis, HIV, and those are the things that we're actually combating here on the Navajo Reservation. I'm going to go ahead and introduce each of the supervisors across the Navajo Nation. If you guys can allow me, Clara, is that okay?
Yeah, just as long as it's a little bit quick, but that would be great. We'd love to see the team.
Good morning and welcome to adding the Navajo CHR program to your webinar. My name is May Jolene Begay. I'm the program director for Navajo Nation CHR Outreach Program. Just for your information, in Indian country, Navajo Nation is the only CHR program that has STD prevention, TB control inclusive as part of the program. And then we're also doing oral health, a new project, as well as a uranium exposure research project. And so we will have each of the CHR supervisors just quickly introduce themselves.
Hi everybody, my name is Tara Klitzo. I am the CHR supervisor for the Chinle Service Unit. I have a total of 10 CHRs and 2 office staff. Thank you.
Thank you.
Good morning. My name is Brenda White. I oversee 2 centers. One is from the Tuba City Service Unit, and then the other is the Kayenta Service Unit.
Thank you.
Good morning. My name is Nana Inez. I am the TB program supervisor, and I oversee 6 staff within the whole Navajo Nation, and each service unit has 1 TB tech.
Good morning, my name is Zena Smith. I'm the STD prevention program supervisor. We have 8 on staff here. We cover 8 IHS and 638 facilities, as well as their 638 the satellite facilities. We also partner with Department of Health, New Mexico, Arizona, Utah, and Colorado. We also partner with various agencies independently. So right now at this moment, we have an increase of syphilis on Navajo. So we're combating that as well. And we also have an increase in chlamydia. Thank you.
Thank you. Thank you so much for the introductions. Oh, great. Okay.
Hi, good morning. My name is Sheila and my last name is Bedoni. I am the CHR supervisor for Winslow Service Unit, and I oversee 8 CHWs and 1 office staff, and I cover the southwest portion of the Navajo Nation. And as I mentioned, there's 8 chapters for 8 CHWs. Thank you. Good morning. Have a good day.
Good morning out there in the world. My name is Verna Begay, and I'm a CHR supervisor for the Four Corners area. They call it the Shipwreck Service Unit. And I oversee, our service unit oversees 22 chapters. I have 19 CHRs with 3 vacancies and an OS and an OA. So we're pretty busy up this way. Thank you.
So Claire, I do apologize. I know you went ahead and you stated to go ahead and do a brief introductions and basically the basic of duties and responsibilities of a CHR. I wanted to share with you exactly the team, the effective team management that Major Lynn Begay oversees to make sure that we provide adequate services for the Navajo people, also as well as when they're giving guidance to the CHRs and the CHWs out on Navajo. Some of the difficulties that we have is internet. There's no broadband sometimes, as well as cell phone services. But each CHR and each CHW is unique. They visit their high-risk clients, as we call them, providing them guidance, letting them and reassuring them that there's actually help there. They go to the Hogan, they knock on the door, they introduce themselves in Navajo and their clanship as well to the elderly people and actually start educating them. They go into the home. Sometimes the home doesn't have firewood. They don't have running water, so they actually bring water for them. Also, as well as they bring in firewood. So each of the CHRs know how to chop firewood and also as well as provide some water and also cook. The other things too is sometimes they get overburdened, meaning like they travel far distances just to visit the elderly people, also as well as the young people, youth, and all the way from birth into old age. They collaborate with other departments, also as well as they develop a friendship, a collaboration between themselves and high risk. So when a person dies out here on the Navajo Reservation, it does hit home.
Yeah.
They have the tools on their in their GSA unit, meaning like their blood pressure cuffs. And the most important thing is the Navajo language. Having the elderly people understand exactly what the illness is and how it can affect their body, interpret it into the native language really helps out a lot. The other thing too is they even get to know the dogs, the family animals, because livestock out here is very important for the Navajo people. It's a livelihood for the elderly people, and that's how they start their day off. They get their paperwork together, they make sure the tank is full, they contact their supervisor that they're going to go out into the field, they tell them exactly who they're going to go ahead and visit, and all the clients are on first name basis. And the supervisor actually knows where they're at all times. Sometimes during inclement weather, they sometimes work up to 12, maybe 15 hours at a time to make sure that medication and food is delivered to them, especially up here in Kayenta, where we have high significant snowfall, where we even have CHRs go on horseback to deliver medications to the elderly people up in the mountains.
Yeah.
So basically, that's a quick rundown of what the CHRs actually do.
Wow. So what I'm hearing is thank you so much, Burnett, and thank you to the whole team there. It's incredible that you guys all came out for this discussion. Very much appreciate it. Thank you for taking the time. But what I'm hearing is you're treating diseases like syphilis, gonorrhea, so the STDs, tuberculosis, and a lot of chronic conditions, diabetes, hypertension, things like that. I'm hearing a lot about partnerships. That's really important that you're connecting to the Indian Health Service and other partners. And I'm also hearing that there's a high risk of burnout. Sounds like it's, speaking the Navajo language, understanding the culture and the customs is absolutely essential. And those are things that I think we've heard in many other contexts, whether we're in Bangladesh or Liberia or here in Navajo Nation. And I wondered, Shreya, can I turn to you a little bit, just now that we have that picture of what's some of the challenges and some of the context of the Navajo Nation, can you tell us a little bit about how that compares and contrasts with what you're seeing in sort of inner city America and Philadelphia? And then bring us also to a higher level, talk a little bit about the theory behind that. So let me turn to Shreya Kangovi. And thank you to the Navajo team. Shreya, I think you might be muted. There you go.
Thanks again, Claire, and thanks to the Navajo team. It was great to sort of get that window into your daily life. Things in Philadelphia and also, Impact does work across 18 states across the country are in some ways very similar and in some ways different. I think the ways in which things are similar is just if you take a step back, and just to frame this in what we're calling the social determinants of health, there's this whole stream of events. It starts at the roots of this. There are deep issues like racism and inequity in public policy and economic policies that create these living conditions that we're talking about, and that create this inequity in access to things like food, housing, transportation, that create, you know, differences in social status and social connections. And that allows some people to have the ability to, you know, have healthy behaviors, while other people are struggling with things like obesity or STDs or addiction. And then downstream from that even are the individual conditions that we then in healthcare have to treat. And so there's that whole spectrum. And I think what's very similar, you know, in hearing from the Navajo Nation and living here in Philadelphia, is that sequence of events is very much at play in the lives of every single one of the patients that we serve. They're really kind of struggling with the downstream consequences of policies that in many cases have been in effect for hundreds of years, things like, you know, racial segregation or redlining. Also, what is similar, I think, is just the amazing and unique ability of community health workers to operate at all levels of this trajectory of the social determinants of health. Yes, they can help people get access to treatments for their downstream actual health conditions. Yes, they can move upstream from there and help them to change their health behaviors. They can help to chop firewood, or in the case of Philadelphia, sometimes they still do have to bring water to folks' homes actually in inclement weather, or help them to get things like housing or transportation. But even further upstream, fundamentally by the nature of us investing in people from the community, we are actually chipping away at the root cause, at the inequity itself. So I think that's an important thing to call out, because we are hiring folks from within the communities to actually do the work. So I think that's really great. What community health workers do here in the impact model is in some ways, again, different from what CHRs are doing in the Navajo Nation, but it's similar in that they do what needs to be done for the patient, right? And that's going to look different in different contexts. In the impact program, community health workers start off by, they meet their patients. They do a semi-structured interview to get to know their patients as people. They do a lot of listening and they do a lot of question asking. They don't do a lot of talking, actually. They ask questions like, you know, where were you born? Who all lived in that house with you? How are the relationships? All the way through, when was the last time you laughed and had, you know, a good belly laugh? And what was the thing that made you happy? And so they sort of, you know, just paint this picture with patients of who they are as people, what their strengths are, because this is not a deficits approach. You know, these communities are not vulnerable, they're resilient. And so they get to know their patients' needs, preferences, goals, and then they ask this very magical question, which is, Mr. Jones, what do you think you need in order to improve your health? And then they use that question to develop with the patient tailored action plans for Mr. Jones to improve his health. So Mr. Jones can say, I need help with, you know, getting stable housing. I need help with finding diabetes test strips. And Mrs. Smith can say, I need a reason to get out of bed in the morning because my son was just murdered. And then they, you know, create these action plans and they provide hands-on support. So they're advocating with Mr. Jones' landlord, but they're taking Mrs. Smith to the senior center to enroll in a crochet class. The actual paths look different for each patient. What's really interesting, one last thing, is that this is the same approach that's being used by community health workers, of course, in Philadelphia, where we've served about 10,000 patients, but we're also scaling this approach all across the United States. So there are, you know, community health workers in, you know, refugee clinic in Tennessee that are using the same playbook, the same semi-structured interview guide, the same supervision structure that we're using here to work with, you know, their patients who might be coming from Nepal. And, you know, same playbook is used by veteran affairs community health workers, you know, in Pittsburgh or in, you know, Dallas, Georgia, in the Walmart community health worker program.
And you know, it's interesting that the you know, that playbook and the model being transcendent across context. I know you found some, you know, you've been able to get some incredible outcome data. Can you give us just a little bit of a window into that, Shreya? And I have a question for the Navajo Nation team, so be ready.
Sure, yeah. I think science has been an important part of what we do, both in terms of informing the intervention and also evaluating, does this work? So informing the intervention, we interviewed patients themselves. We talked to 1,500 individuals on porches, bedsides, shelters, asking them, what do you think makes it hard for you to stay healthy, and how should we design a program to help you? We use that to build impact, and then we tested it in 3 separate randomized clinical trials where we've demonstrated that the program improves access to care and improves mental health. There's some modest improvements in chronic disease control. There's improvements in the quality of care, and there's about a 65% reduction in total hospital days. And all of those translate to a return on investment in the United States context, particularly for a Medicaid payer, for about $2 for every dollar invested within the fiscal year.
Great. And we'll talk about that in a second, Catherine, when we get to the financing portion. But thank you, Shreya. I know that, we all know that measurement is so critical, and it's hard given the variability in programs. But I think, I've really applauded the effort of you and other peers to really be critical, be self-critical, and be rigorous in trying to understand what we're really achieving with these investments into community health worker programs. It's really important. And I want to get over to the financing topic in 1 second, but first there was a question that came through on the Tech Change platform for the Navajo team, and the question is really about prioritization. And Shreya, if you want to speak to this too at some point, it would be great. But how do you, given the breadth of patients that you're serving, the tremendous needs, and everything from chopping firewood, as you said, to helping find housing, how do your CHRs prioritize their patient list and figure out how to spend their scarce, their scarcest resource, which is their time?
Here. Okay, that's an excellent question. The CHR actually are trained, and also as well as they have training on time management. Sometimes we do see burnout, but then again, that's where the supervisor's responsibility to identify such behavior from their CHWs, also as well as their CHRs. The other thing too is when it comes to any type of other additional resources, the CHR program and the CHW program here on Navajo reach out to our resources, other Navajo Nation departments to assist, public health, nursing, also as well.
And Navajo team, it looks like we've lost you.
Oh, she said the internet connection wasn't strong, so I think we're getting a demonstration.
Yeah, no problem. Looks like the Navajo team we've lost for a second, but we'll come back to there and maybe as soon as they're able. But maybe in the meantime, Catherine, if you don't mind picking up on Shreya's last point around the ROI of what we're finding from these programs, and a little bit about, first of making the case. How do we demonstrate ROI? And some of the modeling work you've done for states like Massachusetts and Maine and Connecticut. And then also on coming from that, the bigger part of how do we pay for these community health worker programs in the U.S. and Medicaid, Medicare, grant models. So maybe to start with the ROI sort of discussion, and then to kind of translate that into the broader question of paying for models.
So I'll pick up the phone so it's a little clearer. So first of all, that there's a ton of literature out there that shows that community health worker interventions are effective in improving health and containing costs. Shreya has done some amazing work, but there's a ton across the country. I think it's a very clear, easy, well-documented case of showing that there is a positive return on investment, that if you spend the money on community health workers, that there are positive effects all across the board and there are cost savings. So that's a really easy case to make. Anyone who's looked at it is in full agreement of that. So given that, you think it would be easier to pay for it. And that's really, I think, the crux of the matter. In the US, traditionally, the way that healthcare is paid for is fee for service. So there's a fee for every service. There's a payment for every doctor visit, a payment for every nurse visit, a payment for every hospital stay, and it's broken out that way. And in general, the folks who make these payments didn't want to pay separately for community health workers for each visit, because community health workers provide a much broader service, and it just didn't fit into that model. There are a couple of states in the U.S., Minnesota and Pennsylvania, that do pay a fee for each visit, but in general, most states haven't gone that way. So what's happening instead is across the country, states and health insurers and Medicaid programs are paying differently for care. And so to the extent that there are movements to pay for all of the care for a patient, or a big chunk of the care for a patient all at once, in a per month fashion. So there's a standard payment every month to a care provider to take care of the patient, everything that the patient needs. And when you do that, then the provider can decide how to spend that money. And in many cases, it makes a lot of sense to spend that money on community health workers to actually reach out to patients and provide the care that they need, and not spend so much on healthcare services after the person's really sick. That you can do a lot of care at home in the way that people need, and avoid those health exacerbations.
Got it. Yeah, so it's really about the shift from fee-for-service to value-based care, and CHWs falling within payment opportunities that come from that shift. So things like global payments, bundles, incentives around achievement of quality outcomes. And I know every sort of state is doing this differently and in different kind of manners, and a lot of this came out of the Affordable Care Act. Would you recommend, though, to people who might be sitting in a different state right now, in some ways, do you just move forward with a CHW program and then sort of figure out how to pay for it? Or do you wait for the bigger dynamics around value-based payment to kind of be achieved? And, I'm sitting in a state, Connecticut, that's in sort of the midst of this transformation. How would you time the rollout of a CHW program, whether you're a hospital system or a community-based organization, given the dynamism of the payment environment in the state that you might be?
Right, and that's a strategy question. And Connecticut is actually in a really difficult place because all of the big national for-profit insurers are headquartered in Connecticut. And for whatever reason, they don't want to do things in their own backyard the way they are in the whole rest of the country. If you look at Anthem, some of these big companies, they do all kinds of experimentation all around the country, and not in their backyard. So it's a really funny, it's an unusual kind of dynamic. In terms of how to start, most programs start with grant funding and get grants and use those to train and implement community health workers. And then, of course, the issue is what happens when the grant ends. So my advice would be to, start with the grant, but right from the beginning, from day one, be having conversations with the insurers that the provider works with the private insurer, with the Medicaid program, and say, from the very beginning, if we start this and we make this and we show to you that the patients that we enroll in this program get better care, have better health outcomes, contain costs overall, that we can provide better care in this way, will you fund us going forward? And how can we arrange for that? How can we arrange for the payments to flow in a different way to attain the outcomes that we all want?
Thank you. No, I think that's really helpful, just strategic guidance to be thinking 2 and 3 steps forward to say, well, how are we going to pay for this when the grant funding rolls out, when we want to go to bigger scale, when we want to become integrated with the broader healthcare context, all those kind of things. It's really, really helpful. And I'm sure people have lots of questions for you about that. Shreya, I want to bring you into this too. And can you talk a little bit about, how you finance impact over time, and both as a startup sort of program and then at larger scale? And then what do you see as the challenges and opportunities with financing of community health worker programs?
Yeah, maybe I'll take those in reverse order just so I can also flow directly from Catherine's remarks, which I've enjoyed. So I think that to speak a little bit to sort of the reluctance that, provider organizations and in some cases payers may have towards financing community health worker programs, I think there's a couple of issues. One is, it's interesting, I may not 100% agree, actually, Catherine, about the, universality of, and how easy it is to conclude, wow, community health worker programs have an ROI. I think globally, that's probably true, but I think fundamentally one thing that at least I believe is that there's no such thing as a community health worker program, right? This is a tremendous blanket category for a workforce. So saying community health worker programs are effective, which is things that we say all the time, that's like saying movies are good, right? Like some are, some aren't, and there's a lot that depends on the details. So I do think that savvy investors recognize that there's tremendous variations in program structure, and then as a consequence in the outcomes that each program is able to achieve. And then of course from that, the ROI that each program is able to achieve. ROI is simply a function of a program's effectiveness for moving needles that have financial value. And so there is some work to be done for streamlining that. The other thing to say, which I'm trying not to be too nerdy, but sometimes it just creeps out, is that there's a lot of studies out there that look at ROI for community health worker programs. And again, not to pick on anything that folks have said, but we do sometimes in this field tend to try to be cheerleaders and advocates. And sometimes it gets in the way of our objectivity. You do have community health worker programs that set out to prove their ROI or to make a case. And that is a little bit fundamentally at odds with the way that these things should be done. Science is about disproving your assumptions and testing your beliefs. And that's hard, it's uncomfortable, right? We'd all rather just believe that we're doing a great job, that we're saving money and we're helping the world, but science is about, well, are we really doing that? Like, let's try to beat that down. Unfortunately, a lot of the studies out there are not set up to really be good evaluations for reasons that we don't need to get into, but they're mostly kind of before and after studies, and you can't get really concrete results from studies like that. So all of that is to say, I think that can community health worker programs be effective at improving health outcomes, and can they have a return on investment? Yes. Will they all have that effect? No. Will most of them have that effect? It doesn't look like they will, actually. So that variability is a thing that makes people a little gun shy when they're about to invest. The other thing that makes funders gun shy in investing in these programs is a little bit of a wrong pocket problem. In the United States, as Catherine talked about, the way that community health worker programs save money is by improving the health outcomes that are tied to dollars. And typically that is hospitalizations. That's the thing that drives cost for the insurance companies, which we call payers. And so when you work with patients and you improve their health outcomes and you improve their quality and reduce their hospitalization rates, it saves the insurance companies money. The problem is it sometimes costs the hospitals money because they are paid still in, even as we're shifting to value-based purchasing, providers and hospitals are still paid for hospitalizations. So you have a tension here because the hospitals and the health systems, the provider organizations, are often the ones that are in the best position to have community health worker programs because they're taking care of the patient. Yet they are not necessarily accruing all of the financial benefits that even the most effective community health worker programs can achieve. So there have to be some, an impact. Getting to your point, Claire, what we've been able to do here is, first of all, really be our own worst skeptics, develop what we think is a good product, for patients and for the healthcare system that achieves these outcomes. We are not in the business of keeping patients out of the hospital. We are not in the business of making an ROI. Actually, we're in the business of asking patients what they want and doing that thing. It turns out that if you do that, it does have these other effects, which is actually kind of surprising if you think about it. Once we've been able to demonstrate that, then the question, it's clear that, okay, for every readmission or hospital day prevented, that saves X for payers. It may save Y for providers if their beds are full and it creates an open bed or all of these kinds of complicated things. And what we've been able to do is negotiate joint funding from the provider health system, which wants to do better care for its patients. And gets paid for quality metrics. And, here at Penn, we're at capacity. So it does save money to prevent hospitalizations and reduce bed days. And then we've also been able to get funding from the payer. So that joint funding has been critical. But we work with 50 or so different organizations across 18 different states. And I'll tell you, in every place, the calculus of the costs are different. But what is the same is, let's start with a really evidence-based approach that any funder can actually believe is credible, and let's adapt it for local context and then continue to monitor it over time to see if it's working here like it has in other contexts.
In other places. So being skeptical, being critical, being a scientist and saying, we're not creating a program to prove its value, but creating a program to have impact seems really essential. I hear a little bit of on the line, there's a little bit of background noise, but just to summarize it, being skeptical, being critical, being a scientist, and then trying to really understand how the data will flow across context or not. I want to remind Catherine and Shreya, of course, we have participants on the line from every country who may be less comfortable and familiar with Medicaid and Medicare and the problems of payers and providers not being integrated. I think few of us can keep it straight, and it also varies by each 50 state, each of one of our 50 states. So it's really complicated stuff. But what I do think is common, whether you're talking about the US or African countries with community health workers programs, is this need to look at all the different funding streams that are out there and knit them together in a way that makes sense for your program, and to think about what can I pay for today with grant funding? What can I draw from the private sector, from public payers, from other types, and making sure that you're paying attention to financing streams and dynamics that are kind of coming to fruition within your own context. Catherine, do you want to say anything else about just especially there's a lot of questions coming in about state versus federal level funding streams and how to think about that?
Okay, let me get to that in a second. I just wanted to follow on to what Shreya was saying, which is phenomenal. I mean, you do such amazing work. And she's absolutely right that there isn't automatically a return on investment. And the thing that I found that is key is targeting your intervention and looking at patients. So the trick is, if as Shreya said, where the cost comes in is if somebody's in the hospital. So if somebody is in the hospital, hospitalizations cost a lot of money. Emergency visits cost money, but mostly hospitalizations cost money. And so the trick is to be able to predict who is going to end up in a hospital if you don't intervene sooner. And that requires a fair amount of analysis and really careful targeting. And I'll be interested to hear from Shreya how you do that. When I've talked with community health workers, one of the wonderful things, there are many wonderful things about community health workers, but one of the wonderful things about community health workers is they want to do everything for everyone. They meet a person and they want to do everything. And for a program to actually save money, all of that effort needs to be targeted to people who otherwise would be expensive to the healthcare system. And otherwise you get this different wrong pockets problem. People have many social needs. There are a lot of people who need housing, but if they don't get housing, they're not going to be in the hospital. And so figuring out how to target our interventions to people who have healthcare needs is really, really key. Coming back to your question about, funding in the United States is ridiculously complicated. Don't do what we do. But the way it works here is there are people whose healthcare is paid for by the government and a lot of people whose healthcare is paid for by private insurance that they pay for themselves or that their employer pays for. The public insurance through the government, the federal government, the United States government pays for people who are elderly, who are over 65 and retired or are disabled, are paid for entirely through the federal government. And then each of the 50 states has a state program called Medicaid that is paid for partly by the state and partly by the federal government. And each state has its own plan of what it pays for. And there are rules, there are very, very complicated rules about it, but basically there are a set of services that every state Medicaid program must cover, like hospital care. There are things that state Medicaid programs can't ever pay for, and then there are a lot of things in between that states can pay for in some circumstances.
Yeah.
And every state makes its own plan and gets it approved by the federal government, and the things that the state plan says that they'll pay for, that's how they pay for it. And that the funding is partly from the state and partly from the federal government. So that's probably way more information than you wanted.
Let me stop there, but I mean, the important piece for this discussion, I think, is, some of the most costly patients in the United States are those who are very poor and also those who are very elderly. Not everyone, but that's general dynamics here. And the very poor in the United States are paid for by Medicaid, which is a public program, and the elderly are generally paid for by Medicare. Some are eligible for both kinds of support. So you have the federal government thinking very much about how to keep the poor and elderly healthier and out of the hospital. And then you have a range of private insurers who are also very concerned about controlling costs. Then you have a hospital system that actually wants, in some cases, patients in their hospitals because they get more money.
Right.
So CHWs play a role in all of this, and it really depends on whose perspective you're taking to understand what are the incentives and how can we kind of do the right thing by the patient, most importantly. But generally, the federal government and state level governments are very concerned about controlling costs, and therefore they're very interested in solutions like community health workers that can be really important for driving down costs and also for keeping people healthier. Just to stop there on the financing question, we could nerd out all day. It's very complicated. But one thing that when we work with African countries, that's really critical is often, helping them come up with regulations and laws around community health workers. And those will be national strategies, but then also national implementing guidelines around CHWs and how those become part of the broader health system. Can you maybe, Catherine, talk a little bit about regulatory structures around CHWs in the US and what states, for example, are way out ahead in creating rules about CHWs, what roles they can play, should they be recognized or certified and accredited? Who's really on top of the certification and regulatory space?
That's another hard question. So again, in the regulatory world, for most healthcare professions like doctors and nurses and physical therapists are required to have a license. And there's a national set of skills that everyone needs to have, and you have to pass an exam. And only people who have passed that exam can do those things. That doesn't exist for community health workers anywhere in the United States. There's no bar that says you must have this set of skills in order to do this work. So because of that, payers, particularly the private payers, but also the state Medicaid programs, the public payers, the Medicare programs, don't understand how do they know that this person that's right here is a qualified community health worker, has the knowledge and skills to be a community health worker and to be effective in doing this work. And so states are one by one working on certification programs. So something that shows that this person has the knowledge and skills to be a community health worker. And states do it in all different ways. Some require an exam, some require specific training courses, some require specific supervision, some require someone to have observed that person working and say, you know what, that person, they really have those skills down. Rhode Island requires a portfolio of work that somebody's done in the community that shows how active they've been and how effective they've been. So I'm not sure that I could say that there's any state that's way ahead of any other state. They all approach it differently, but I think that the point of certification is to have a piece of paper, to have a system that has determined that this person has these set of skills and that, you know, as a state, we've decided these are the set of things that community health workers are really helpful at doing, and this is how we know that this person has that knowledge and skill to be able to be effective in that role.
Thank you, Catherine. Yeah, it's definitely a changing landscape and really state by state, but each state trying to figure out a way to, one is to make sure that people who may not have academic credentials can still be included in a CHW program, but then also to, you know, to Shreya's point a little bit, of trying to figure out ways to ensure quality of programs, and sometimes that can start with the individual, sometimes not. And I wondered, Shreya, if you can talk a little bit about that and give your perspective on what types of certification and regulation are helpful around CHWs themselves and CHW programs. And then to take it up to another sort of higher level, one of the questions that came in is sort of about, you know, why don't we have a national framework at a federal level for CHWs, and sort of specifying the type of certification and accreditation that would be helpful?
Yeah, absolutely. So, and I just want to return Catherine's compliment. I just enjoyed her overview. I feel like I learned about healthcare financing in the United States from hearing your remarks. I think it's interesting how we're having this conversation. I just want to point out it's so healthcare centric, and it's a little bit of what has been called a target-oriented approach to community health workers rather than an empowerment frame for community health workers. We're basically you talking about using community health workers to achieve the outcomes that health insurance companies and hospitals want to achieve. And we're talking about certifying them in the way that we certify nurses and doctors. So I just needed to point out that we have this bias that we're bringing to this work that is hundreds of years old, that is grassroots, that is grounded in a whole different ethos. So I'll come back to that, but I think it plays a role in how we think about regulations. I 100% agree with Catherine that there's a problem, that there's two problems really that we're trying to solve. Number one, there is great variability in whether any given community health worker program works or not. And payers need some sort of good housekeeping seal of approval to be able to say, I'm investing my money wisely and I'm not wasting my money. The other problem that we're trying to solve is for community health workers as a workforce to be able to achieve legitimacy in this very health-centric world that we live in, and say, I have this good housekeeping seal of approval. And so I can get promoted and I can get, you know, a raise and advance in my career. So with those two goals in mind, it's understandable why states might think, okay, well, let's do what everybody else does in healthcare, which is certify an individual based on whether they have completed a training or, you know, checked this box and gotten a certification. The problem is there's two problems with that approach. Number one, there's no evidence that it works at all. Actually, the Agency for Healthcare Research and Quality just put out a draft report that I would encourage everybody to take a look at that reviews the evidence for certification. Again, what I mean when I say certification is certifying an individual CHW based on whether or not they've completed a training requirement, or in some cases, you know, experiential requirements, but it's at the individual level. It doesn't seem to be associated with the overall effectiveness of any given program. And if you take a step back and you remember what folks from the Navajo Nation talked about, what we've written about, what has been written about from the developing and global health context for hundreds of years, that makes tons of sense, right? Because just an individual CHW's training or even their skills isn't the only thing that matters for program outcomes. What about, you know, are we hiring the right people to do the job? Who is supervising them? What are their caseloads? Are they being safe when they're out in the field doing their home visits? What is the theory of what they're doing with patients, and what does the actual intervention model look like? Hundreds of program level factors probably matter way more, or at least as much, but probably more to the overall effectiveness of a program than just, oh, let's check the box, you finished this training. So that's problem number one. It probably doesn't work. Problem number two is it could actually hurt, right? Because who are community health workers? Community health workers fundamentally are people who share life experience with the patients they serve. They share educational attainment, they share language, cultural background. They're their patients in many ways. And so the other part of who they are natural helpers. They are the kind of person who's gonna bring soup to a neighbor, whether they're asked to or not. These people actually may be weeded out by certification requirements. If they can't afford, you know, sometimes training and certification is not free. And if you can't afford that, that could weed out the natural helper who would have otherwise brought soup to a neighbor. If you can't read well, or if you don't speak English well, or whatever, you know, you may not take that test. Or if you've had a history of incarceration, you might just like, I don't even want to be certified for anything. I don't, or if you're undocumented, you may not want to interact with those training and certification systems. So there are a lot of worries about that. So what do we do instead? And to your point, Claire, actually, the NCQA, the National Center for Quality Assurance, and my Center for Community Health Workers are actually exploring an early stage partnership to think about national program level standards. So this wouldn't just put the burden on community health workers, it would put the burden on employers of community health workers, the folks who actually have the purse strings and can control not just, you know, the box checking of training, but what's this program look like? And what are the workplace standards for how these CHWs do their job in terms of, are we hiring the right folks? Yes, of course, are we training not only them, but their supervisors, their program directors? Do they have adequate supervision ratios? Do they have reasonable caseloads? Are they getting burnt out like Burnett is talking about? So I think that's really a critical holistic piece, not only because that implementation science from global work points to those factors as more important for determining outcomes, but because it's a labor issue, it's a justice issue. Community health workers, if you think about that social determinants landscape, they're people who have faced injustice, and we shouldn't pile further injustice on top of them by having them work in conditions that aren't good.
Yeah, and it you know, in a lot of cases, you know, if I drop my young children at a daycare center, I want to assure that that daycare center has been regulated by the state of Connecticut. And, you know, we may also want those teachers to be certified, but there's probably at least a question about both sides of the equation. And I think that makes a lot of sense, kind of where you're driving toward. But it's something that is being debated, and it's a live topic, and I don't think there's necessarily one way to do it. Unfortunately, our colleagues from the Navajo Nation, I think they've had some technology challenges. I was hoping to ask them about this as well, and what types of training and certification that they're requiring, but hopefully they'll be able to call back in, and perhaps otherwise we'll find another time to connect with them. But I want to pick up this point a little bit about quality at scale and sort of how do we build a bigger movement? And there's a financing piece, obviously. There's also a certification piece. One of the tech change participants asked a good question about political motivation. And, you know, often in the global context, we say, you know, if only the Minister of Health or the head of state were behind CHWs, then it would really take off. And, oh, but, you know, maybe if a big donor came in and made an initial grant, and then that would really accelerate progress, and we could, you know, put pressure on that way. But what do you both see as really critical to going from, whether it's 100,000 or 200,000, hard to say, CHWs now, to seeing CHWs in different contexts, and maybe retail clinics, Walmart, you mentioned Shreya, but CHWs really operating in every health and social setting that we can imagine them being useful. What are the bottlenecks, and what can we do? If you want to start, Shreya, and then maybe I'll turn back to Catherine.
Sure. Yeah, I think we're coming to a point in the United States where, you know, a larger number of people are experiencing what it means to have some real life challenges that can affect their health. And I think in some sad way, we might be getting closer to a tipping point where more and more of the population will use their political will to sort of demand that in general, our country is more responsive to the real life needs our people. And by real life needs, I mean everything from, you know, how am I going to feed my kids tonight, to where am I going to sleep, to I'm sad and lonely. Yes, these are challenges that are most concentrated in high poverty neighborhoods and communities, but it's a gradient, and that gradient has really never looked as steep in the United States as it does at this minute. And so on some level, I think the answer to your question hinges on whether people use their political voice to advocate for these types of solutions, and whether effective solutions are ready for decision makers and leaders to deploy when they are pressured to do so. On a more narrow healthcare level, I do, you know, for better or worse, think that we are a little bit stuck with that, you know, context of the target-oriented frame. You know, right now, when we talk about social determinants of health and we talk about community health worker programs, it's often in the context of how do we reduce healthcare costs, and how do we, you know, just get to this certain end that we're trying to achieve. What's been very exciting and surprising and gratifying, at least about the work that we've done with Impact, is that there are a lot of programs that have tried to solve that problem, i.e., you know, address social needs in order to lower hospitalizations and lower costs. And what's been really ironic is that the ones that try to do that head on, you know, who are really focused on targeting, quote, the super utilizers, and who are all about, you know, the end metrics and things like that, they haven't succeeded as much. And what we've done, and you know, others have done, but what we've done is take a very different approach, which is like try to kind of ignore that, box checking a little bit, and just really make this 100% patient centered. You know, just what do you need, Mr. Jones? And we're going to do that thing. And you know, our community health workers, for the longest time, we didn't even tell them that we were measuring readmissions or hospitalizations in our clinical trials. And even to this day, they're very carefully trained. Don't keep your patients out of the hospital. Do what your patient needs. And the beautiful irony is that that holistic patient-centered approach may actually do it all, you know, improve patients' lives. And we all have a lot of stories about that, but also, you know, do the kinds of targets that we're all focused on, whether they are healthcare targets like, you know, mental health or smoking rates, or cost targets.
Thank you. No, I think that's that beautiful irony. I hope it plays out. It seems to be in the case of your program and several others. It's important. I like the framing of the box checking exercise versus the holistic patient view of what do you need to be successful in your life, in your day. It's really important. I think it's an important mindset shift for a lot of us to have. Catherine, just to bring it back to the brass tacks a little bit, but if we actually want to do this in a way that empowers patients and pays for CHWs to do whatever patients need, how are we going to pay for that at scale? And what needs to happen to make this where do we start? State governments, federal, Walmart, employers?
I don't know. I think a little bit of everywhere. I mean, I love Shreya's idea about certifying the programs rather than the people. I think it's brilliant. You know, our country is completely polarized politically right now. And one thing that I found that is interesting is that there's huge amount of support for community health workers across the political spectrum, that we disagree on lots of things, but once people understand what community health workers do and how they do it, people generally support that work regardless of their political views. And, you know, when I was working in Maine, and there was a very conservative Republican governor there at the time, and he was totally sold. I'm not sure how much it helped, but he totally got that this was the way to go. So this is the questioner who said, you know, who do we get into this? Who do we need to be the supporter? I think that we do need to get influencers to know about community health workers and know how they work. And I'm not a social media person, so I can't tell you how to do that. But, you know, there is a world out there of how do we get people to think about a new idea and really buy into that this is the way to go? And I think we need to start campaigns at that level. You know, I think for community health workers, go meet your legislator. That would be the number one thing I would say. Go see your local, you know, your state reps, your Congress people, your senators. Go visit them. Go, you know, make an appointment and go say, this is what we do, and we want you to know about it. And I feel like we need to have some really strong grassroots work across the country. There are people in every district for community health workers who are working community health worker issues, and yet our political structure doesn't know anything about it. And so I think we need to start there. I mean, yes, get into your Medicaid program and health insurers and all those other people, but I would start with the politicians and just let them know what you do.
Totally. I think that's great advice, just sort of becoming a presence in your state and making sure that people are even aware of this thing that doesn't just exist someplace else, but is actually a very real part of our society. Two questions that came in actually from a former minister who's on the line, who I will keep anonymous, but thank you very much for your questions. She's asking about, you know, one, the risk of malpractice lawsuits, and if we're handing too much responsibility, or can there be a risk of people taking action if it feels like an untrained CHW is handling something? So what's the risk of malpractice? And then second, you know, there are a lot of Americans, I don't have the current figure in front of me, but who are without insurance. And are those people being covered by Medicaid, or are they paying out of pocket if they're being served by a CHW? So how does it work for the uninsured or the undocumented who may not have access even to Medicaid? And if Catherine, if you want to start, or Shreya, if you want to jump in.
I'd love to start on the malpractice piece, and then,
sure.
Or if you want to take it in reverse order, Catherine, it's totally up to you.
Go for it, Shreya, if you want to do the malpractice.
I think the answer is yes. I do think that there is not only the legal, but the real medical potential for adverse outcomes if community health workers perform, you know, clinical care or even health education that's beyond their scope. I know that may not be the popular thing to hear. And I, again, think that community health workers do what they need to do. So it's going to vary depending on the context and the availability of trained clinicians. So I know that in, you know, other, for example, I worked with a community health worker program in rural India, and there were no clinicians. So community health workers performed clinical care, and they probably saved lives. So you know, being said, in the United States, either through direct contact with clinicians or remote contact with clinicians, there tend to be some level of access to clinicians. I am not an education person. I don't have a strong bias that like everybody, you know, needs to have a lot of letters behind their name for every job. But I do think that for clinical care, I'm a primary care doctor. I'm really awed by the complexity of medical information that exists right now. So to even provide basic health education to one of my average patients, I have to scratch my head a lot, you know, to say, well, a normal blood pressure is 120 over 80, but for you, Mrs. Jones, because of your heart failure and your vertigo and blah, 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 I might not, you know, I might say that your blood pressure should be X. So I worry about community health workers getting into that lane because of those outcomes, also because of turf struggles, regulatory issues with other trained clinicians that I think are well-founded. So the way that we have solved for that in the impact model is that CHWs are the quarterback of care. They're the ones that get to know their patients. They develop these tailored patient-driven action plans. When you ask patients, what do you think you need in order to improve your health, you'll find that most of the answers are not clinical. It is often things that community health workers are very well positioned to address independently or in collaboration with their supervisor or existing social and community-based resources. Again, things like, oh, I need somebody to advocate with my landlord, or, you know, I'm lonely, let's go plant an urban garden. When there are clinical issues like, you know, oh, I've run out of my insulin, or I don't know how to take this medication, the community health worker connects them to a clinician. They do not provide that clinical care or health education themselves. And that has been, I think, really critical in easing people's worries about adoption of this model.
Yeah, no, it's big. And we see it also in Africa and in parts of Asia too, with this question about lanes and turf and litigation. And it's all very real. we're almost out of time, but Catherine, can you speak for maybe 20 seconds about this uninsured question? And then I have one final question for you.
Well, the short answer is people who are uninsured don't get enough care. So that's just put that out there, and it's very unfortunate. It's one of the things that I would not copy about the United States if you're in another country. There are programs, it depends on where you are, in Seattle, King County, in Washington State on the West Coast. There's very strong county government that provides all kinds of services to uninsured. In Massachusetts, where I am, there is a sharing among private hospitals of caring for sharing the burden of caring for uninsured patients. So each locality does it a little bit differently, but mostly not so well. Short answer.
Yeah.
Time for me to say one more 5 seconds.
Yeah, please.
I would caution folks not to let financing drive the structure of your community health worker program. Build a good program, ideally using a proven model that you adapt for your local use, and then pull in varying funders depending on what they may get out of the outcomes that you are going to achieve. So you are covering, Medicaid patients from, like Medicaid pays into the pool, but also the providers pay into the pool because they don't want uninsured patients to have uncompensated care, and philanthropy pays in because they want the social good. But the end product is a seamless community health worker program that is not fragmented.
Yeah, no, that makes a lot of sense.
Here to that, and if it's a strong program, you will have the data to, make sure you're collecting data, and you'll have the proof that you need to bring to the parents.
So I'm going to turn to Magnus in 1 second to conclude us, but one final question for you, Shreya, and something that there's a lot of questions about too, is the career path of CHWs. And, as an example, babysitter here that wants to be a CHW, she learned about it, and she's now in nursing school because she could not find a program in New Haven to actually, that was using CHWs that she could become a part of. So how do we think about recruiting CHWs, giving them access points, and then a career path for them, whether it's remaining as a CHW or doing something else in the social service workforce?
I want to hire this babysitter if she's the right person. When we recruit community health workers, that's how we do it. We don't prioritize any pieces of paper or letters behind names. We do meet and greets in the community. We look to see whether they have the traits like empathy, non-judgmental nature, listening skills, and then hire based on that. So that's the recruiting and hiring piece. And that's been one reason that we've had a 1.7% turnover rate over the past decade, while most programs have had 50 to 77% turnover rates. We're hiring the people who want to do this job and that are good at it. Then we actually just did a study that we presented at APHA where we interviewed community health workers about what they want in a career path. There's a theme here. We talk to people about what they think and then do that thing. And community health workers told us something surprising, which is, because we've hired people who are natural helpers, they want to keep doing that. They want to get promoted, they want to get raises because everybody wants that, but they don't necessarily want to become nurses or social workers or go off into different careers. So we've developed something called career paths at my center that has a core track where CHWs can get promoted as community health workers. And then there's an options track, which is smaller, where community health workers can also get promoted into different branches like training or advocacy or management. And then I do think that employers should provide tuition assistance and professional development funds. And that's something that we bake into the costs of the impact program. So when I talked about the ROI, this is all into it.
Fabulous. No, that makes a lot of sense. And just saying, some people want to be CHWs, they're natural helpers. They should have options to continue that. Some others may say, it's something slightly different, and that should be okay too, but providing that optionality based on people's preferences. Thank you so much to you both, Shreya and Catherine. You're fascinating and brilliant women, and I'm so just in awe of what you're doing. There are a lot of questions we didn't get to, questions about the opioid epidemic and what CHWs can do, and different kinds of, specific conditions like that. That's, how do CHWs fit in with maternal health? But we don't have time. So what I'm going to do is encourage people on the call who have those questions to email you both to ask your questions. There's follow-ups that will come from the Tech Change platform and from the Community Health Academy team, how you can reach everybody. But thank you so much to you both for your insight, for your work, and for your time. And let me now please turn it over to Magnus to just give a few last comments.
Thank you, Claire. I am also in awe of these two fabulous ladies who have enlightened me so much. I find it difficult to even close this session. I want this session to continue. The discussions have been really informative, lively, and hitting at the core of the challenges that we have with providing health care for underserved populations, but using community health workers who are also part of those underserved populations. And Sharia, you mentioned the word, they have experienced social injustice themselves. And then we are piling on top of that other challenges of not paying them, not compensating them, not recognizing the burnout. And Catherine, you mentioned the policy challenges around financing, supporting this kind of programs, establishing this kind of programs across different states in the US. Some of those policy vacuums that exist in the US mirror some of the challenges that also exist in developing countries. You also mentioned, Catherine, the issue about developing programs and embedding sustainability strategies within that process of developing those programs. And Sharia, you also mentioned the importance of not certifying the people, the individuals, but certifying the programs and developing these programs around the needs of the patients so that we are patient-centric in terms of the way we develop these programs. You also mentioned the importance of not just training the community health workers and focusing on the education of the community health workers, but on the whole comprehensive system strengthening, the context in which these programs are implemented, the context in which the community health workers work. And that speaks to an approach that the Community Health Academy is trying to focus on, which is ensuring that our training is a health workforce capacity building program, starting from training community health workers to their supervisors, to their managers, and to health systems leaders at the national level. Because if the enabling environment does not exist for community health workers to implement their programs or to do their work, no matter how educated the community health workers are, those programs are going to fail. So I have to say that this has been a very enlightening webinar, and I hope that participants online have found it useful. And I just want to say how disappointed I am that the Navajo Nation team were not able to continue with this discussion. I was very impressed by the motivation they demonstrated through their introduction and how powerful the issue of speaking the language of the local communities and translating the healthcare needs into the local language and local context. Behavior change communication is something I believe in. And I was at a conference in Nairobi recently, the core group conference, where they mentioned, somebody mentioned that not all community health workers need to be literate in English. They need to be literate in their local language. I will end with that. And thank you so much, Claire, for your fabulous facilitation skills. And thank you all that work behind the scenes to make this webinar possible. Taylor and Noreen, thank you both. Bye, everyone.